والآن مع محاضرة Updates on the Management of Acute Pulmonary Edema in the Emergency Department by Dr. Ahmed Alludie, Doctor degree in Emergency Medicine from the University Kapangsaan, Malaysia. Board Certified Emergency Physician, Malaysian Conjoined Board. Last but not least, a Masters of Medicine degree from Singapore. فلتتفضل مشكورة.
السلام عليكم. وجه التحية لأساتذتنا الكرام منهم كل الزملاء في طب الطوارئ، وشكرا لكم على الحضور. نحاول ان نخلوا شويه انتراكتيف ونبدا المحاضره بعرض كيس. قبلها نحاول نتعرف على الحضور، يمكن نعرف منه اللي يشتغلوا في الامرجنسي ديبارتمنت يرفع يده. اللي يشتغل في الاي سي يو، يعني اغلب الحضور خارج الامرجنسي ديبارتمنت والاي سي يو. السؤال الثاني، من اللي عنده سنوات خبره اكثر من 4 سنوات في الامرجنسي ديبارتمنت؟ الكيس هي 67 years old, male, known to have CHF اللي هو ال outdated name. بنقدر في update بنقول له acute, known to have heart failure and hypertension. Presented to you in ED with history of sudden onset, severe difficulty in breathing. Patient looks unwell, diaphoretic. When the patient is sweating, it makes you sweat. Patient pale, and he looks about to crash. Vitals of AMS in the hospital shows that heart rate of 140, blood pressure of 180 over 118, saturation of room air was 80, and just the paramedic told you that the patient that he hear the forced respiration up to mid-song. So the first question, what's your initial management of this patient? أي حد حاول يتفضل. Should تعطي الأكسجين, high flow mask, non-rebreather, there's a cannula, saturation of 80. Next slide, please. لو فرضنا انك انت already patient triage to resus, attached to monitor, started on non-rebreather. شنو هي حسب رايكم؟ تشوفوا في الاجابات ولا مش واضحه ولا واضحه؟ مش واضحه. A, get IV access, draw blood for investigation, and start furosemide, Lasix, at dose of 20 milligram IV. Who thinks A is the right answer? Okay. B, start IV Lasix, 80 milligram stat dose. Who think this is most appropriate? Okay. C, get 12 ECG, 12 lead ECG, portable chest X-ray, get IV access, blood for investigation, and start Lasix at 40. It sounds the right answer, right? Okay. D, get 12 lead ECG, portable chest X-ray, get IV access, investigation, insert urine catheter. It's very important because you're going to give Lasix, you want to monitor hemodynamic during output. The answer E, give IV morphine because patient is in anxiety, air hunger, very stressful, agitated. We don't want to see you not even put the mask on his face. So morphine, 2 milligram, sublingual GTN, nitroglycerin, and IV Lasix 40. You say yes? This is the right answer. Why? Because this is the first time you see GTN. No, what's the why? Because it sounds the right answer. How about if start IV infusion of GTN with starting with the 20 mic per minute, then Lasix 40. Next slide, please. Hey, okay, before this. Yeah, the right answer is none of the above. So that's why we are here. We try to know what is the update, what's the proper management of this case. First of all, we have to know that terminology is important. المصطلحات هي ضوابط الوعي. انك انت تضع المصطلح المناسب يعينك في فهم pathophysiology, the category classification, and then helps you with the proper treatment. الحالة هذه اللي احنا شفناها اللي هي اسمها الاسم الحديث او الابديتد سكيب. سكيب اللي هي sympathetic crashing acute pulmonary edema اللي من فترة كانوا يسموا فيها فلاش pulmonary edema. ليش مهم ان احنا نحط التسمية؟ مش نعرفوا straightly from the first word sympathetic rule. And aim of management is going to be towards that. الهايبرتنسيف نعرفوا ان الاكيوت هارت فيلير is a broad spectrum variety of presentation. Patient can present it from cardiogenic shock, whereas the hypertensive patient can present it with just overload. Another name for this is a subacute pulmonary edema. And the extreme of the disease is state. Sympathetic crashing acute pulmonary edema. شنو الفيتشرز نتاعها اللي هي نلقوا الفيتشرز نتاعها اهم حاجه نلقوا rapid onset of respiratory distress within 6 hours. Usually acute heart failure presented within days, 2-3 days, but they reaching the tipping point where everything goes to the vicious spiral cycle and ended up with crashing acute pulmonary edema, marked tachypnea, dyspnea, hypoxemia. Hypertension usually systolic blood pressure is more than 160, and MAP of 120, more than 120. You can hear diffuse rails on auscultation. Sometimes you can see pink frothy sputum. But the most important is the clinical feature of sympathetic activation, which is diaphoresis, pallor, appearing extremely unwell, tachycardia, and agitation. The pathophysiology مهم. The first model was invented to explain why acute pulmonary edema happened was in 1940s. They called cardiorenal. It's simply the heart cannot work properly and do not perfuse the kidney. In emergency, we try to simplify things because it's our character of our specialty. We are in hurry. And we have to be simple, understand simple, and act very fast. So as simple as that. In 40, it was very simple, but they say, okay, the heart is not working properly, do not perfuse the kidney properly. And then what happened is renal retention and systemic retention, and that's why acute pulmonary edema. And that explanation was the motive of using furosemide. They think is systematic congestion is happening, not pulmonary congestion. And then in 70s, the new model, which is a cardiocirculatory model, that emphasized the role of afterload.
Assalamu alaikum.
Peripheral constriction and pulmonary vessel constriction, increasing the afterload. And that explained actually more about acute pulmonary edema, but did not explain why patient is crashing rapidly within 6 hours. What happens? Only in the 90s, when they invented or they come up with the RAS, renin, angiotensin, aldosterone, that's explained why patient is crashing very fast. Why importance of this pathophysiology? Because that's guide our management. يعني vicious cycle, increase afterload, MAP, aggravating the heart failure, and then cause fluid back up into the lungs, which is causing pulmonary edema. And this happens very fast, and every part leading to the part is very fast. If you forget all about this detail, just remember, most patients with escape are EU volemic. More than 50% of patients presented with acute pulmonary edema actually EU volemic or hypovolemic. So what happens is pulmonary congestion, not systematic congestion. So our management plan should be emphasizing reduce of afterload, because the problem is when the patient presented with a high blood pressure means afterload problem. The heart pushing against high resistance, against the strong wall. So we need to overcome this resistance by reducing the afterload. And the other problem is the preload issue. In diastolic volume, in diastolic pressure, increasing the load of the heart. This just simplify things again. Just imagine it's a bathroom where you have a source of water coming in and you have a drainage through the tube. This drainage through the tube is afterload. If the tube is small and you push against this, then you're facing a high resistance. And this is afterload issue. If this water is still coming, still leaking, still coming to you, this is the preload issue. And then it's a failed heart, not normal heart. So it's a struggling inside. So we have to reduce the load by reducing the input and reduce afterload by making this drainage or hose bigger. What's the new, or I think it's a new, is NIPPV, non-invasive positive pressure as a first-line management for patients presented to you with dyspnea, hypoxic, and hypertensive acute heart failure. This is your first-line management. When you did not see this as a first line, and then the answer should be wrong. And it's not only in IPV, in concomitant use of vasodilator, which is GTN. High dose of GTN. That's another update. Using of point-of-care ultrasound. This is not update. This is a revolution of emergency medicine treating acute pulmonary edema, because it helps you diagnose, put your differential diagnosis. It guides you for your management. It also helps you assess the hemodynamic status or volume status of the patient. And treat underlying cause. If you don't know the underlying cause, and then you cannot treat. So that's a point-of-care ultrasound rule as well. NIV من الناس اللي يشتغلوا في الامرجنسي ديبارتمنت، من اللي يستعمل في الان اي في his management of acute pulmonary edema يرفع يده. مش هنسال سؤال. ممتاز. الان اي في اللي هي عندنا نوعين معروفات، السي باب continuous positive pressure ventilation، وعندنا الباي باب. باي باب يقولوا تريد نيم يعني زي الكلينكس وزي اللي هو البي باب الاسم اللي try to avoid generic this issue. So BiPAP and CPAP. The difference is that CPAP provide pressure, airway pressure, continuous pressure during the whole cycle, inspiratory and expiratory. The BiPAP gives the delta between inspiratory pressure and EPAP is the driving force. EPAP is equal to P in CPAP. There is another lectures in our Lima provided about the NIV. It's very helpful. I think uploaded in the Lima site. Yeah, it's simplified approach and it's very, very helpful. It's an NIV improve oxygenation by inflating the collapse, extending the alveoli, improve the perfusion VQ mismatch, and then increasing the intrathoracic pressure. That's increase the FRC and reduce preload. The FRC is, just think of FRC as زي البنزينه، خلف البنزينه اول ما يبدا المؤشر ما هذا هو الريزيديو اللي ما زال عندك باش يصير هذا الاف ار سي. You have to improve FRC and then NRV help you in this. طبعا robust evidence RCTs meta analysis prove that NIV prevented patient from getting intubation and ICU admission. Some controversy about mortality, but remember, the disease itself, acute heart failure, is a fatal disease. 50% of the patient will die within 5 years. So that's why the mortality, but as an emergency physician, robust evidence that NIV improves symptoms, decrease walk of breathing, patient becomes very comfortable within 10 minutes. Actually, reduce intubation and decrease work of breathing. This is the studies. Number need to treat from 8 to 13, which is a high number, epidemiological point of view. Before NIV, acute pulmonary edema means the chance for junior doctor to learn how to intubate the patient. The NIV is the enemy of junior doctor to learn. You see how I make things easy for you to remember the NIV importance of treating acute pulmonary edema. وهذه اشكال طبعا الفيس ماسك للاورو نيزل والنيزل وهذا الهلمت. Tips. Before you initiate the NIV, try to talk to the patient, try to do some coaching. Give the patient a mask. He should hold by himself. Gives him زي ما تقول انه هو يحاول انه ياخذ بروحه، يعني يحاول انه يحطه لما يقدر، يحوله بشويه بعدين يحطه لغايه ما يتعود. Start sitting by low and then increase or titrate up your sitting according to the situation. Coaching very, very important. Patient is agitated. Sometimes the patient really agitated, really anxious, you can give low dose of opioid. In this case, maybe we advise fentanyl over morphine. Morphine, actually, the studies that shows morphine increase more in APO is usually the high dose, more than 5 milligrams. So that's why European Society against using of morphine, but HAFSA, which is the American Society of Heart Failure, is still advised to give low dose of morphine. Morphine, if my answer, morphine is no APO. If you have to use as an anxiolytic, use fentanyl, 50 ml. That will improve or reduce the air hunger and agitation of the patient, and he will cooperate with you in IV. Starting of CPAP, usually 6 to 8. You can start 6 to 8 simply. And then titrate up to 12 to 14. Remember, try to not reach the 20, because at the 20 pressure, that's when your esophagus is open and you cause insufficiency. Using BiPAP or CPAP in acute pulmonary edema, there is no difference, much difference in outcome. The study is not sure about that. But in case of, you know, an emergency department patient cannot come, just cannot come in COPD only. Sometimes the triggering of heart failure is a COPD. In COPD, you have some sort of CO2 retention. In CO2 retention, BiPAP will help, increasing the inspiratory pressure, and you play with the CO2. This is a setting price you can start with. And remember, concomitant use with a high dose of GTN. because the Canadian Cardiovascular Society suggests IV nitroglycerin is taken used in all its hypertensive APO, and because there is a report that any dose below 100 GTN actually do not decrease pulmonary capillary wedge pressure, meaning that any dose that we give below 100 is unlikely to cause the needed effect. This is a swan catheter studies. Because at low dose, you reduce only preload, you venodilate. At higher dose, more than 120, you only start to do arteriodilate and reduce your afterload. So this is the concept behind why we shift to the high dose. If you want to be conservative, you can start with 60 mic per minute, but titrate up very fast. Reach 300, 400, it's safe. GTN is very safe. It's short acting. Very rarely cause hypotension in the case of state. And if hypotension happens, within 5 minutes of stopping the drug, it will be okay, or just adding small amount of crystalloid. It's very safe, robust study about pre-hospital use of sublingual GTN. You can go every 5 minutes up to 6 tablets before you starting your IV GTN. New study in 2002 last year suggested that it's very safe to give high dose GTN as a bolus. This is actually the pilot study, prospective, about 25 patients presented with this state. They give them all in IV with a high bolus dose of GTN, and they go very high. They actually suggest a protocol of management, which I see is very pragmatic, very practical to use in our ED. If you don't want to follow this protocol, at least back in your mind, know that it's very safe to give high dose GTN. That's their protocol, as you can see. They start GTN bolus of 600 mic per minute. If the blood pressure, systolic blood pressure from 160 to 180. They give 800 if the blood pressure from 180 to 190. And they even give 1000 mic per minute. So that gives you impression that our dose that we usually, or we used to give 20 mic per minute is a homeopathic dose. It's not. Initiation of BiPAP is, they use actually BiPAP in this study, and the inspiratory pressure they put at 12 and EP at 6. And always remember, it's the delta wave which gives you the pressure support. So if you want to change patient sitting from 10 and 5, 10, 5, inspiratory 10 and deep 5, do not change it from 25 to 20 because this is different, still 5, and we will change nothing. Is this concept clear? I mean, the driving or the delta between inspiratory pressure and expiratory pressure is the driving force that you play with, especially if you are targeting oxygenation. You know, when we are targeting the oxygenation, we use deep. When you are targeting CO2, we play with inspiratory pressure. Sometimes we increase the inspiratory pressure without any increasing in beat. We got 0 beat. Okay. Morphine, no to morphine. To summarize that, treat underlying cause by using point of care ultrasound. Point of care ultrasound not only diagnose D lines for acute pulmonary edema, but also you can shift the probe a little bit to the heart, see the contractility, ejection fraction, rule out any tamponade. You can also use the IVC to know if this patient is really fluid overload, that you can use Lasix as a third line, or do not use the Lasix at all, and also can help you to rule out other diagnoses like pneumonia, ARDS, myocarditis in case of COVID, and etc. All these studies are about why we do not use the Lasix as a first line, because Lasix, if you use it as a first line, it's a harmful. I summarize all this study by this word. If you want to use it only as a third line after you reduce afterload and preload, and after you confirm by point of care ultrasound that this patient is really overloaded. Professor Mervyn is one of our teachers who always talk in his lectures about we are happy carrying the urine bag of furosemide and explain all this pathophysiology against using furosemide. If you want to learn more about point of care ultrasound, we are happy to help in Lima, inshallah, in courses of ultrasound. As you see, sensitivity of ultrasound is exceptionally high for diagnosed EPO. Just X-ray 20% can be normal. So it's very clear stethoscope is useless. And this is the way when you put the probe, the point you see, and this is the P line. Is it difficult to learn ultrasound? This is a conversion study. Compare people who are they teach them how to perform for the first time, and they compare them with the expert in point of care ultrasound, and both can do the same. So it's very easy to learn point of care ultrasound, but practice makes perfect. Ultrasound also can differentiate cardiogenic versus non-cardiogenic pulmonary edema. And I have to say, we need to learn more about point of care ultrasound, and then we join the course. Thank you very much. And as